As healthcare professionals, we work in the NHS. Sometimes we can be in a position where we have a finite amount of resources available to us. This is never more evident than now. With the numbers of babies with RSV-positive bronchiolitis soaring, we have to think about how we're going to best manage our resources. Now, bronchiolitis has no evidence-based medical therapies. The fundamental tenets are treating hypoxia, giving some form of respiratory support, and making sure that the baby has enough hydration. In recent years, we've started to use heated, humidified, high-flow oxygen via nasal cannulae. It's become really popular, things such as Airvo or Optiflow, and is backed by solid evidence to support its use in babies with bronchiolitis. It's worth mentioning that with the novel coronavirus, there's been an increased focus on what we call an aerosol generating procedure. The RCPCH guidance says any form of high flow humidified oxygen is an AGP. So that means wearing full PPE when you're using it. How do we optimize our resources? How do we use our Airvo to the best of our ability? So the first thing we think about is how do we know which babies need it? And how do we risk stratify which babies we use it on if we only have one machine? Let's look at bronchiolitis. It's a spectrum. It progresses from mild to moderate to severe. So when we're thinking about using non-invasive respiratory support, it's the moderate category that we tend to be looking at. If we only have a few machines, we have to pick and choose which babies will benefit the best. We know that actually we don't need to start all babies with bronchiolitis on Airvo. We can focus on using it as a rescue treatment rather than just prophylaxis. So when we're looking at our children, we're going to be using a dynamic assessment to determine which way they're heading. Are they getting better or are they getting worse? And which patients really need that support? So in general, when we talk about non-invasive respiratory support, such as high-flow nasal cannula oxygen, our children fall into two broad categories. They're either previously fit and well, who just need a small amount of support to get them through the illness, or they're more complex babies, those with a high hematocrit, who are small with low birth weights, born premature perhaps, or with underlying chronic lung disease. And that distinction is quite important because it's these more complex babies that tend to be more likely to fail the interventions such as Airvo. When we're looking at our children and our patients in front of us, how do we decide when to start? Well, there isn't any standard consensus. It really depends on the patient in front of you. If they're hypoxic, if their SATs are less than 92 on room air, then first start nasal cannula oxygen, humidified if you can. If they remain hypoxic, that's when we need to think about using Airvo. And that cutoff is really important because it tells you if they're in the progressive phase of bronchiolitis, if they're getting worse before they get better. Other things that we can think about are the degree of respiratory distress, if they're really working hard, if they're tachycardic, if they're dropping their GCS, or if they're having apneic events. So if your child is hypoxic or hypercapnic plus an increased work of breathing, just start them on Airvo straight away. So once you're ready to start, what are we looking at here? Well, generally we start at 2 litres per kilo because there's no evidence that higher flows either give better support or stop it failing. And what do you do when you've used your Airvo? Even if your Airvo has been used for the patient most likely to benefit, you may find yourself with more babies needing respiratory support. So what are you going to do then? Humidified nasal cannula oxygen is the next best thing. You can run it at 2 litres per minute. It's not expensive. And if you can humidify it, it means it's going to help clear all those copious secretions. And that's really important because otherwise your babies are going to plug off, de-recruit, and it's all going to deteriorate. If you have CPAP, that's another option, but it depends on what your department's used to. Who's going to fail Airvo? So the key to using it is dynamic assessment, as we've said. Babies that are going to fail tend to fall into that complex category. They're low birth weight, they're premature, they have high HCT levels, or they have an underlying chronic lung disease. These babies need to be carefully looked after. You can increase their likelihood of doing well if you swaddle them because it helps calm them down. It decreases their metabolic rate and it increases the chances of success because babies like to be held. Now, bronchiolitic babies will tend to declare themselves quite early, and you can usually tell within an hour or max 2 if they're going to be successful at settling on that Airvo. So if they're settled, great job. However, if they're not settling, you're going to think about what you're going to do next. Let's look at what failure looks like. If you've started Airvo and it's been running for a couple of hours, what's going to tell you it's not working? Look at the baby. If they have ongoing severe respiratory distress, if your FiO2 is going up and up, and we're thinking about numbers of 50 or 60%, with an inability to maintain oxygen saturations more than 92, you're going the wrong way. Particularly if they're having apneic episodes, their GCS is dropping, or they're just not comfortable and they're fighting it. That's when you're going to need to think about escalating your support. There's a great deal of inter-hospital variation on what you do if your patient fails on Airvo. So it's going to depend ultimately on your department and your staffing skill mix. But it's worth thinking about it because some machines can be switched to provide BiPAP, an increased level of respiratory support that actually could be seriously useful in stopping that route heading down towards intubation. If you've had great success and your patient is settled on Optiflow or Airvo, where are we going next? How long are they going to be on it for? And when can we get that precious machine back to use on someone else? Children's respiratory response is generally reflected by their weight and their age. Heavier, older children get better quicker, and that's just down to physiology. If you've got children aged 6 months to a year, you can anticipate probably 2 to 3 days on Airvo. But the younger ones, the under 6 month ones, they're going to take maybe a bit longer, potentially up to a week. And they're obligate nasal breathers, so it takes them longer to feed as well. So when we're ready to stop Airvo, which route are we going to go down? Well, there's no consensus, and it generally falls into 2 categories. There's no evidence at the moment. The ABC trial's recruiting, and that's going to look at which way is best. They're looking at reducing the flow by 50% as a single step prior to stopping, and that's what the RCPCH guidance is as well. In terms of where you're going to look after these children, the idea is that all the babies get settled on Airvo and remain at district general hospitals, and that leaves PICU free for the sicker children. Now, obviously, that doesn't always happen, but everything we can do to support that is going to help take the pressure off our PICUs. If these children are previously fit and well, so not the complex ones, they don't need HDU levels of care. You can staff them in a bay 1 to 3 or 1 to 4, depending on the experience and skill mix of your nurses. Now, if you do need to move the babies, say for example you're cohorting them in one location in your trust, it's worth thinking about how you're going to do that, because lots of ambulances only have 2 pin plugs. Now, you can get converters, but you need to clear them as medically safe. So what else can we do to prepare for this upcoming potential respiratory surge? Preparation is key. We're a community, and we're joining forces to upskill and prepare for the upcoming winter 2021. If we want good outcomes, efficiency, and good patient and parent satisfaction, if we want to avoid escalation in our patients, we need to focus on the ground routes. We ideally need more machines, more capacity, we need rapid testing, and we need to familiarise staff with the use of BiPAP so we can avoid that escalation. If we can upskill, if we can train staff on the use of BiPAP, we'll help to relieve pressures on stretched transport and PICU systems. And we are, as a community, forever grateful to ongoing fantastic resources from organisations such as the Retrieval Services and PCCS, which continue to be a fabulous asset. Good luck for the coming winter.